Dear colleagues, again, it's a pleasure to talk about the huge epidemic we are now facing with non-alcoholic fatty liver disease. And of course, I will mainly focus on new treatments, but as you know, as we have no licensed treatment, but so many patients with this non-alcoholic fatty liver disease, I would also like to show you what we can do now, what are the current data with anti-diabetics, anti-lipid drugs, and so on, in order to give you a nice overview. So let me start quite briefly with definitions and epidemiology, and I think you are aware that it's really a global epidemic, and in nearly all countries around the world we are facing around 25%, a quarter of the population have some form, some kind of non-alcoholic fatty liver disease, and the highest prevalence, as you can see here, is in the Middle East. And even if only a very minor percentage of these patients will end up with advanced liver disease, you can easily imagine that this will leading cause of liver failure, hepatocellular carcinoma, and liver transplantation in the future. So what are the terms, the definition we have? So non-alcoholic fatty liver disease is a kind of an umbrella term. It means all people with some forms of fatty liver not caused by alcohol or drugs or any other reason. And then it can be subdivided into the steatosis or the steatohepatitis with different degrees of fibrosis. But to be honest, for this classification, you probably really need a liver histology to make a firm diagnosis. And the histologic features you are looking for, if you would like to separate the fatty liver, the poor steatosis, from the non-alcoholic fatty liver steatosis, the main issue here is not the steatosis. It's quite similar in both. The definition is more than 5% of the hepatocytes being steatotic. It's a question whether there's any evidence of hepatocellular injury. And what is a marker of hepatocellular injury? It's a ballooning of the hepatocytes. So the NASH means there is some inflammation, but also signs of hepatocellular injury in form of ballooning, and this can be with and without fibrosis. Just a simple inflammation within fatty liver without ballooning does not mean NASH. This can be still a non-fatty liver. And this is a typical example of this ballooning. As you can see here, this very large, I hope you can see it, this very large hepatocytes being enlarged, not anymore in a proper form. And the reason for this ballooning is a destruction of the cytoskeleton of the hepatocyte. So it's clearly a severe injury of the hepatocyte that is induced by this fatty liver. It's not just only some fat droplets within the hepatocyte. So how to define the form, or how to really make a histological diagnosis of a NASH? And here the gold standard is a NAS score, like you know the scores for viral hepatitis, where we have the METAVIR score. And the three important parts being within this score is the level of steatosis. You have different points, the degree of lobular inflammation, and as I mentioned, the degree of ballooning. And a firm diagnosis of NASH can be made if the NAS score is 5 or greater, and if there's it's less than 3, then it's no NASH, and there's some consistency and uncertainty in between. A brief word on the natural history, and I have to say that probably we do not have really a complete picture on the natural history, because we do not have good evidence from a population level. It's most coming from referral centers where we have repeated liver biopsy, but I think it gives you an estimate what can be expected. So in patients after a follow-up of, let's say, around 10 years, steatosis may show some signs of NASH in 10 to 40%. You see the huge range, so a lot of uncertainty about the progression of the disease. And this may come to advanced fibrosis in 5 to 10%, so only in a minority of these NASH patients. And if you have advanced fibrosis, again, up to 50% may develop cirrhosis with a high risk of decompensation and also hepatocellular carcinoma. What is concerning is that even for patients having a, let's say, fatty liver, pure steatosis, some may progress rapidly to advanced fibrosis, and those with early NASH to cirrhosis. And we do not have a good explanation, or we do not know well the characteristics of these patients who may rapidly progress from one stage to the other. And there are some studies showing that it doesn't make a big difference for the individual, whether an individual starts with a pure steatosis or with an early NASH diagnosis in terms of progression. So you need some individualized follow-up. I think a big concern is really regarding HCC. And of course, if you have liver cirrhosis, that's quite clear. The rate of developing hepatocellular carcinoma is quite similar as you've seen for alcoholic cirrhosis, viral hepatitis-induced cirrhosis, in a range of 1% to 4% per year. But what is cumbersome that if you look, for instance, in data from Asia, that if you look at the HCC being on the bottom of a non-alcoholic fatty liver disease, that 30 up to 50% of them, HCC induced by non-alcoholic fatty liver disease, are not in patients with a liver cirrhosis. They are at earlier stages, sometimes only NAFLD, or most of them NASH. And this is really something difficult to address, and we also do not know at all how medication can help in this direction. When I move forward to show you some of the mode of action of new targets addressing fatty liver disease, I think it's important also to understand the pathophysiology, and that it's not only, let's say, a disease that involves the liver. There are crosstalk between different tissues and organs, and most likely the crosstalk between the gut and the liver is very important. A dysbiosis induced by diet leading to a leaky gut, and due to a leaky gut, these DAMPs and PAMPs via the portal vein lead to an immunological innate immune reaction in the liver, bringing the inflammation into the steatosis. And quite similar, the visceral ectopic fat, the adipose tissue, may contribute via the adipose cytokines, and also the pancreas and insulin resistance is involved, as you know. And probably underestimated is the role of genes. Of course, there are environmental factors that are associated, but the individual gene signature of a patient is probably really a very important driver, and in my view will help in the future really to individualize our treatment approach, our management approach, and it helps the patient to understand, while he, with the same body weight as his neighbor, with the same behavior with respect to diet and so on, has developed a significant disease and the other not. It's the same as the issue with alcohol intake, that some people are protected, the others not, and it depends to a certain amount, at least 30 to 40% on the genes the patient has. So let's move on to treatment strategies, and if we are thinking about treatment, we have first to ask who is at risk. We don't have to treat this fatty liver in a quarter of our populations. And it clearly turned out from a liver standpoint, from a liver point of view, that only those with advanced fibrosis are at risk to develop significant liver-related morbidity and mortality. And it starts slightly with an F2, as you can see here, but mainly after F3 and F4. And that's the reason why most companies now targeting the F3 and F4 population for their investigational drugs. So how to detect these people at risk? So as I mentioned, we can't biopsy all of them, that's for sure. So we need non-invasive markers. And the most commonly used, and I think they are really easy to use in the clinical practice, are the non-alcoholic fatty liver disease fibrosis score, the NAFLD score. And you see there are parameters we have easily in the clinic. It's the age, it's the BMI, whether diabetes is present, ALT, platelets, albumin, and you can calculate it via the internet. Or the FIB4 score, quite similar like the APRI with an age, AST, ALT, and platelets. So this is easy to obtain, and there are several guidelines showing that you have a patient, let's say with ultrasound, there are evidence, or due to the behavior of the patient, being obese, diabetes, that there could be a risk of non-alcoholic fatty liver disease. You can do these tests, and if the NAFLD score or the FIB-4 score is very low, so excluding significant fibrosis, you will just give some advice with respect to lifestyle modification, diet, and so on, but no further follow-up in this respect. But if there are signs of significant fibrosis, probably you need an expert, and then you can go on with FibroScan and so on, and think about any medications. I think here probably a more practical way, what is the pretest likelihood of having significant fibrosis or a NASH or not? So for instance, if you have a patient with signs of fatty liver by ultrasound, but he's below 40, he has no diabetes, the AST is normal, the likelihood of having significant disease is very low. And it's always what we have seen in the adulthood, that those with lower ages normally have not advanced fibrosis. But this may change because more and more children are now overweight, so this can completely change the field. However, if you are age above 15, you have certain risk factors like obesity, diabetes, the AST is elevated, then the likelihood of NASH is quite high. Probably you even don't need a biopsy to make this diagnosis. But the amount or the stage of fibrosis is always difficult to judge. So what are the therapeutic strategies? How should we treat? And I would like first to highlight the guidelines. There are more recent ASLD and EASL guidelines. So what is written here? Because as you know, we do not have licensed medications. So the management of NAFLD should consist of treating the liver disease as well as the associated metabolic comorbidities, such as obesity, hyperlipidemia, insulin resistance, and the type 2 diabetes. As patients with NAFLD without steatohepatitis and any fibrosis have excellent prognosis from a liver standpoint, the pharmacological treatment should be generally limited to those with a biopsy-proven NASH plus fibrosis. This means you need a liver histology. What is the EASL guideline? I think it's quite similar. It's a recommendation for structured lifestyle changes. Then, and I will show you the data, for those being overweight, obese, the aim, the target is a 7 to 10% reduction in body weight, but with pharmacotherapy, this again should be reserved to stage 2, F2 and higher. But what kind of treatment? That's a big question. So what about lifestyle modification? Any meaning in the weight loss medication? Well, you know this slide. I think it's quite nicely highlight what you can achieve just by losing weight with this target of 7 to 10%. You see you have a NASH resolution in more than 60%, a fibrosis regression in 50%, steatosis improvement in 70%. And you have to keep in mind these numbers when we're coming to the new drugs that are now in clinical development, what they can achieve. The problem here is that only 1 out of 10 achieves this level. So although it works, it's probably not practical, and we have the same with all these type 2 diabetes, cardiovascular disease, hypertension, that lifestyle may help, but nevertheless we have to treat hypertension with pills because these lifestyle modifications are very difficult to achieve. Any use of weight loss medication? Well, they are not really studied in clinical practice, and especially for NASH patients. In most of these situations, there is no insurance coverage for the patient. But what you can see here, and I hope you can see, that the mean weight loss with all these different drugs, probably orlistat is well known, is in the range what we would like to achieve. Around 10% can be achieved. But most of them are not studied in non-alcoholic fatty liver disease, only some of them with orlistat showing some improvement, but no controlled studies. But what are very interesting that they are the GLP-1 agonists leading to some improvement and also to weight loss, and I will show you some data in a minute. It's always a question by the patient, and you're advised whether patients with non-alcoholic fatty liver disease should drinking any alcohol or should stop completely. And the ASLD guidelines say, well, of course, you should not consume heavy alcohol amount. Of course, then it's not anymore non-alcoholic fatty liver disease if you have a heavy consumption. But there's insufficient data to make recommendation with complete stopping. And there are really, just to highlight here, several studies looking at the amount of alcohol intake in alcoholic fatty liver disease, and many of them showed that if a patient stopped completely drinking, the prognosis is worse as compared to a very, very moderate drinking. That means less than one or a maximum one drink per day. But of course, if you drink more than 1.5 drinks a day, the prognosis is worse. And I think this is mirrored really in many studies that a complete stopping is not always associated with an improvement, quite often with a, let's say, more deterioration of the disease. And it's also my personal experience when patients come with elevated liver disease, signs of fatty liver disease, and they told me, well, I stopped alcohol for 4 weeks, but then the liver enzymes went up, and probably you can make the same experience. It's quite striking for those really not drinking a lot. Coffee, I think you can recommend. Probably the effect on steatosis is less clear, but the improvement in fibrosis is shown in many of these large studies. And here, one study showing that also the occurrence of non-alcoholic fatty liver disease, there's a clear dose-response relationship. The more coffee, and it starts around 2 or 3 coffees per day, you have a risk reduction for the occurrence of NASH. Now I would like to move forward to the pharmacological treatment, and as already stated, no drugs are approved, no specific therapy can be recommended, any drug treatment is off-label, so probably I can stop here, but I would like to show you what is around, what is in the literature, what have been seen with different drugs. And if you remind the pathophysiology and of the process and the progression of non-alcoholic fatty liver disease, you may easily imagine that depending on where you are, you may have different treatment targets. So in the beginning, targeting insulin-resistant metabolism or lipotoxicity, the oxidative stress, can be very important. In the stage of more advanced NASH, immune modulation or targets of inflammation might be more interesting. And if fibrosis increases, anti-fibrotic or anti-apoptotic drugs might be useful. So for the time being, I think we have the situation where patients early on, probably with insulin-resistant B and overweight, they are more in the cardiovascular risk situation and treated in this direction. However, when it comes to early NASH, we have some substances like the pioglitazone, vitamin E, insulin sensitizer, and the anti-diabetic drugs that might be of some help, and they are licensed for the diabetes. And if the NASH progressed to stage 3, 4, I think this is a domain of clinical trials with all the new substances. To briefly mention pioglitazone, it was the first substance to show some benefit. The benefit for vitamin E was even higher. There are several randomized trials all showing that the insulin sensitizer, it's a nuclear receptor agonist, the PPR gamma agonist, has some beneficial effect. But so far from the current guidelines, well, they can be used, that is the message, in those with or without diabetes mellitus, and the risk and benefit should be discussed on an individual level. The same holds true from vitamin E. It can be used, and also the ASLD guidelines do recommend these drugs in early stages. The optimal duration is unclear, but if there's no improvement in ALT after 6 months, the recommendation is here to stop. A few words on the GLP-1 agonist. And I think these are very interesting substances because they have shown in patients with fatty liver disease, and this is an early phase 2, the LEAN trial published in the Lancet, that you have a nice weight reduction here around 6 kilos within the treatment period, and this was followed by an ALT decline of around 30 units. and an improvement in NASH in 40% as compared to 9% in the placebo. You will see these numbers all the time, that the placebo group always show an improvement in the level of 9 to 15% or 10 to 15%. So there's a huge interest in these substances, and especially for the GLP-1 analog semaglutide, and this is now used in phase 2 studies in patients with more advanced NASH and even NASH cirrhosis. What about the lipid-lowering drugs? Well, haven't shown any significant benefit in patients with NASH, but I think it's important that in a patient with NASH you do not stop statins. Even if a patient had a liver cirrhosis, it was shown when the disease is compensated, when you stop statins in a patient with a compensated cirrhosis, your prognosis concerning the mortality is worse as compared to continued statin use because of the multiple positive effects statins have on portal hypertension, fibrosis, and inflammation, probably also cancer. So now coming to the more new drugs being in development, and what we are aiming for, the ideal drug is, of course, a drug that would positively regulate the lipid metabolism, steatosis, inflammation, improve the underlying insulin resistance, and has antifibrotic effects. But most of the substances we have so far targeting the metabolism, here you see the list is very huge, the inflammation with different drugs and fibrosis, the ASK1, for instance, is a very interesting drug, and I will show you some data, and also the fibrosis. What I would like to do in the following is really to briefly touch only 4 typical substances. I wouldn't like to go into detail with all the different substances because the results overall are quite similar. All these substances are in phase 3. Elafibranor, we do not have the phase 3 data, but I will show you phase 2. For obeticholic acid and FXR agonist, we have the phase 3 data, also for selonsertib, and it improves inflammation and fibrosis, and Cenicriviroc in the same way. Here we only have the phase 2 data, but phase 3 data are waiting. The PPAR nuclear receptor agonists are very interesting substances, and elafibranor targets both the PPAR alpha and delta PPAR, and this has multiple positive effects on lipid metabolism, insulin resistance, inflammation, probably also on fibrosis. The phase 2 study showed a nice decline in all the different markers and also an histologic improvement, but you see, as in all these studies, the difference is not huge. It's doubled the improvement, but a more pronounced difference was seen in those with more advanced NASH. So the phase 3 trial is ongoing, including F1 to F3 patients with a NASH score of greater than 4. What is probably interesting, in these studies, and this is with all these phase 3 trials, that's at an interim analysis to see that there's improvement in NASH. But if this interim, we have a positive result, then these studies all enter a long-term study to show clinical endpoints, because by EMEA and FDA, they will all ask for endpoints before licensing these new drugs. Targeting inflammation, a typical drug here are the chemokine receptor antagonists, CCR2 and CCR5 signaling, and these drugs inhibit the migration of inflammatory cells into the tissue, and so they have an anti-inflammatory and anti-fibrotic effect. And again, you see here the phase 2 data, so not so easy to obtain a significant result. As you can see here, overall with a NASH score there was no improvement, but there was a significant improvement in fibrosis regression, and therefore the study entered phase 3. Now we come to the 2 phase 3 studies where we have the clinical data yet. And the one that was really with a high interest that awaited were the data from the Gilead selonsertib NASH trial, a huge program targeting patients with F3 only, and those with F4, the STELLAR 3 and the STELLAR 4 study. And as I mentioned, it's an ASK1 inhibitor, and ASK1 is triggered by oxidative stress and has multiple effects, also in lipid metabolism to some part, but in inflammation and fibrosis. So in a way, it's an ideal target to inhibit this pathway. But And here's the big study. But what turned out, there was nearly no effect, a completely disappointing result. Placebo even did better as a treatment in the A3 fibrotic patient or in those with cirrhosis. Therefore, they're aiming now for combination therapy, and I think this could be a solution. And they are interesting collaboration with the anti-diabetic drug provider here with the semaglutide, with other factors, with other treatment drugs. And I think it could be the future, this type of collaboration. And the last study I would like to show is the most important one, because here for the first time we have positive results with one of these new drugs in phase 3. So it could be that this substance become licensed, and this is obeticholic acid. It's already licensed for a cholestatic disease, primary biliary cholangitis, and it's an FXR. It's also a nuclear receptor agonist with multiple action, mainly in the bile acid metabolism, but also in the lipid metabolism. It had effect on inflammation and also targets, I will show you in a minute, also the gut-liver axis. This is the design of the study. 2 different dosages of obeticholic acid were investigated to placebo, and fibrosis improvement by 1 stage without worsening of NASH was a primary endpoint. And this primary endpoint was met. You can see it's nearly doubled from placebo to 23%, 12 to 23%, that the patient had, after 18 months of treatment, a 1-stage reduction in fibrosis. But again, as in all these placebo-controlled trials, just by putting a patient into a study, so is interested to lose weight or what, however, means that you have a 10% improvement. This was the intention to treat. If you look at per protocol, so these patients were able to take the medication. The effect was even bigger, not so much for the placebo, but for the higher dose group with nearly 27-28% improvement in fibrosis. And there were also some patients that improved fibrosis by more than 2 stages. As you can see here, there were 13% as compared to 4% in the placebo group. So overall, you see more patients showed an improvement in fibrosis and only a minority, a deterioration, and this was completely different in those with placebo. But these data also show you that not all patients do respond. Even some may progress. And so far, we do not have any data, and they are so far not disclosed from these studies, what are the characteristics of the patients responding or not. So this type of individualized treatment strategy is still missing. I think what convinced me is also the ALT response. You see again in the placebo group some decline, but a very nice and rapid decline early on after starting treatment for ALT, GDT, and also AST on treatment. And I briefly touched this gut-liver axis because I think it's really a very interesting target in all our future approaches to target people with fatty liver disease. And FXR is expressed also on the intestine and also modulates the response via the FXR response, via the intestine. And there's a recent mice model, and would like to finish with it just to put it into a perspective, where mice were fed with a NASH diet, and this NASH diet induces a dysbiosis. And by this dysbiosis, there is a leaky gut, and the leaky gut with all the bacterial products entering the liver versus a portal vein are a major driver for the progression of NASH. And what was interesting in this mice model, that by giving obeticholic acid to this dysbiotic lumen, it completely blocked the leaky gut issue and preserved, and these mice did not develop any more a fatty liver. So, Mr. Chairman, ladies and gentlemen, I would like to make a few conclusions. So NASH is a growing and common cause of liver-related morbidity and mortality worldwide, and is projected to soon become the leading indication for liver transplantation in the US and probably all over the world. The fibrosis stage is the strongest predictor of liver-related adverse clinical outcome in patients with NASH, and there are currently no approved pharmacological therapies for NASH. But I think the GLP-1 analogs and other anti-diabetic drugs are likely to be hepatoprotective. The pharmacological treatment of fatty liver disease should be reserved, but should be reserved for those with advanced fibrosis. And these patients with very advanced fibrosis, I think, should be referred to expertise centers to evaluate for ongoing clinical trials. And from the phase 3 data so far, we can conclude that the data for obeticholic acid are really promising, but you see how difficult it is to achieve really a significant effect by the disappointing results of selonsertib. But we are soon awaiting more data from large phase 3 trials. So probably the bile acid, enterohepatic drugs and anti-diabetic drugs are competing in a neck-to-neck race, whether they will be the most important one to treat NASH. Combination therapies could be probably the solution for the future. I haven't mentioned bariatric surgery, but of course this can be helpful for the fatty liver disease. But so far we do not have an indication for bariatric surgery solely for NASH. And I think it's important to learn more about the natural history disease to get to a personalized and targeted treatment in this huge community of patients and people being affected. I thank you very much for your attention.